Thank you, Rishabh boss, for giving me this opportunity. So I will be quickly looking at the data, and the data is huge, and we will keep it very. So NSCT versus adjuvant, it is a token of the hour, and when we see the data, we become perplexed whether to take new adjuvant, whether to take adjuvant. Everything, data for everything is now available. You need to choose, and choosing wisely remains the key. So early stage, despite why we need treatment, new adjuvant or adjuvant, because we know even in early stage of disease, the survivals are not crossing 7 to 8 years. That means at least 20% patients will not survive more than 5 years, even at stage one. So that is an important point. This is the staging. I'm not going to the detail. If we see the perspective for perioperative systemic treatment, this is the stages where there is definitely a role of early treatment in the perioperative setting. It includes stage 1B onwards and definitely stage 3A. So this is for the perioperative treatment. Adjuvant treatment for stage 3 treatment, I'm not discussing. This is the overall survival. Even for the stage 1A disease, the survival is 82% at 5 years. That means 18% patients are not surviving, and this is dropping down to 36% for stage 3A. So that means a significant big chunk of patients are not surviving even at 5 years, even when they are presenting at early stage. So definitely neoadjuvant versus adjuvant, this is the perioperative treatment, and we know surgery is definitely removing the bulk of the tumor, but microscopic disease which is remaining is important to be removed by the neoadjuvant or adjuvant approach. Neoadjuvant approach, we are discussing this from the time of breast cancer, where we discuss neoadjuvant treatment. It has the potentiality to eliminate live tumor cells which are released during circulation during surgery, and adjuvant treatment is what is the advantage? It has the advantage that patient can undergo surgery at the onset directly. So this is the lung adjuvant cisplatin evaluation. This we are knowing from the time of our DM training that patients more than 4 centimeter get the maximum benefit, and that is why it is the standard of care. Even in neoadjuvant treatment for the chemotherapy, the part is known. If for coming for the EGFR, since EGFR is we are not focusing on EGFR today, but this is very important data. Just I wanted to highlight it. ADORA, it clearly showed adjuvant osimertinib is causing hazard ratio up to 0.17. So this is very important. Let's move towards IO approach. Definitely, it is important to be noted that patients even in EGFR positive, there is some role of neoadjuvant treatment. What is the importance? Because now new ADORA study is also ongoing, and that has started to enroll patients even in our country. And EGFR positive patients, we know that chemo and immuno do not work too much well. That is where most of the study try to exclude it, but we'll see the data for the same as well. So yes, EGFR, it is clear, it is causing very significant benefit, at least in the terms of DFS, and OS data is being awaited. So let's take the immunotherapy as perioperative treatment in EGFR negative population. So this is the pivotal study, IMpower 010. Let's see the study design. The patients receive adjuvant chemotherapy for 1 to 4 cycles. This is what I wanted to highlight. All the studies, even ADORA, they have tried to give the adjuvant chemotherapy, complete the adjuvant treatment, and then start the treatment with either immunotherapy or targeted treatment. So no study has tried to exclude adjuvant chemotherapy. But in reality, as discussed, adjuvant chemotherapy is received by at least only 50% of the patients who are the candidate for the same. This is a very important point to be noted. They do not receive adjuvant chemotherapy due to risk of various complications and various logistic constraints. So in this study, patient received 16 cycles of adjuvant atezo versus supportive care alone, and primary endpoint was hierarchical evaluation of DFS in 3 populations. We'll see the stage 2 to 3A with PD-L1 tumor proportion score of more than 1% was the first, and later on they evaluated OS as well. So these 2/3 were male, 2/3 were non-squamous, and 2/3 were white population. Stage 1B around 12%, 40 to 45% stage 2 and 3A. PD-L1 1% more were 55%. To be noted, EGFR positive were 11%, ALK positive were 3.3%. So these are the subgroups which we have highlighted. If we see the stratified hazard ratio in the primary endpoint, that is the DFS in stage 2 to 3A with PD-L1 TC score more than 1%, hazard ratio 0.66. So if we directly see the 3-year survivals, DFS survival, it is 48% versus 60%. So it is clear it is seeming to be benefiting the patients, and this is very clear. Whether it is benefiting the patient with EGFR mutation, we cannot say, because this was a small percentage, 11% only, 43%. But still in this subgroup also, the diamond was towards the left, that is in benefit of atezo. This we will not be sure to use it, but if we have no better options, for example, till the time new ADAURA data does not come out, we can utilize this treatment as well. And if we see the data overall, other patients, so all the patients, the curve is towards the left only. Whichever chemotherapy is being used, whether patients are node positive or node negative, all patients, it is towards the left. And if we see the all patients, irrespective of the PD-L1 status, again, there is improvement in the DFS. It is some definitely lesser in PD-L1 unmatched patients. It is 49 versus 55%, as against 48% versus 61%. So yes, the quantum of benefit reduces in non-PD-L1 selected patients. Again, if we see the PD-L1 positive patient, yes, PD-L1 more than 50% patients are seeming to get the maximum benefit. Hazard ratio is towards less than 0.5. So again, we know PD-L1 more than 50%, as in case of metastatic setting, is able to select the patients for getting the maximum benefit of this treatment. So this is the subgroup, which is where we should be very enthusiastic to use the treatment. If we see the PD-L1 less than percent, is it exactly at 1. So again, it is an important point. PD-L1 less than percent, though the study and the endpoints included PD-L1 unselected population as well, but the primary endpoint was PD-L1 more than 1%, and that is why we think this study came as positive, and it is very clear. So these are the various subgroup analysis. Let's move ahead. This is the early OS data. There is some benefit in terms of atezo. OS data is definitely immature presently, and it is not reaching 50%. If we see the safety data, yes, it seems to be quite safe. We have our experience with utilizing immunotherapy in a lot of patients, and definitely the benefit is maximum in PD-L1 more than 50%. Yes, finances are an issue. Can we restrict it to patients with maximum benefit? Yes, I think so. PD-L1 more than 50%, I will be more happy to utilize these immunotherapy, which are the costly treatment options. Well, if we see, there is EMA approval in for stage 2 to 3A, PD-L1 more than 50%. FDA approval is more than 1%. So European countries have stronger, stricter approvals, and we can clearly see it is the subgroup which is getting the maximum benefit. That is more than 50% PD-L1 and EGFR negative. It seems that we can adopt the same criteria in our settings as well. This is other data, adjuvant pembro data. Will not take it up in detail, but definitely hazard ratio of 0.6 again. So it seems to be working well, and the benefit with PD-L1 more than 50% was again somewhat higher, but it was not so pronounced as case in the atezo data. This is might be due to smaller sample size. So again, let's come to some other treatment options. First, this was about adjuvant treatment. The problem with adjuvant treatment, you have to go at least 16 cycles of treatment. While in neoadjuvant setting, only 4 cycles are usually enough, 4 to 5 cycles. We'll come to just that data as well. So this is the neoadjuvant data. This is Checkmate 816 pathological response and survival study. It is clearly utilizing patients nivolumab 3 weekly versus standard chemotherapy. Patient underwent surgery within 6 weeks post-treatment and optional adjuvant treatment. So if we see 16% patient could not undergo definitive surgery, but this might happen even in patients who are planned for surgery and do not receive neoadjuvant treatment. This is very common. All patients who are planned for treatment do not undergo surgery. This is important. If we see the PAT-CR rate, the patient who achieved PAT-CR, they are having a very, very extraordinary benefit. Neo plus chemo is able to shift the curve in terms of benefit with PAT-CR patients. The curve shifts to hazard ratio of 0.18. So that means the patients who are having PAT-CR with Nivo plus Immuno, they are getting the maximum benefit. They are predicting as good survival as with the new ADAURA data, with ADAURA data. So definitely PAT-CR, if patients are achieving major pathological response or PAT-CR, they are the subgroups which we can predict to be having maximum benefit. So it is important. This is a good option where surgery might be challenging and relapses are high, and the long-term DFS and OS are awaited. But there is more data. NADIM study is also there, where PAT-CR rates are close to the tune of 63%. So there is difference in the outcomes. It is to be noted. There are more data which is awaited, and this is the guidelines. So So to just conclude in brief, there is absence of direct comparison between neoadjuvant and adjuvant immunotherapy. Both are valid options for different patient subset where there is a potentially resectable or questionable fitness for surgery. Better to go ahead with neoadjuvant treatment. Another advantage with neoadjuvant immunotherapy, the cost will be less because patient will receive only 4 to 5 cycles. Patients who have those have a smaller disease at the baseline, they can undergo resection first. Those who have negative margins and adequate thickness can undergo adjuvant chemotherapy followed by immunotherapy. With this, I again reiterate, choosing wisely remains the key, and we need to choose the best treatment for our patients. Thank you.